This is the Mettleset. Dr. Jordan, we are so excited to have you on the show finally, because you have been on our guest wish list for a while now, especially because a lot of the athletes that we have interviewed since we launched the podcast in October, Melina Timpson, who you may know, Dara Sahab, who you may know, have spoken really, really highly about you.
Yes, we've got so many questions. And, you know, you are one of the best in the business, in the sports medicine business in the UAE. And you've had an extensive career working with international teams, including the British Olympic team, Scottish Rugby and Football, and the Scottish Institute of Sport.
Yeah, and now along with the work that you do with patients at MediClinic, you're currently working with British Swimming and for World Rugby as a tournament doctor and a medical educator.
Yeah.
Great.
That is a lot of credentials.
And that means you're busy and traveling all the time. So getting you on the show, that's a get.
Yeah, we really appreciate it. I guess we're really looking forward to the chat. We have a lot of questions for you. And we've also asked some of our listeners to send in questions. But we want to put the caveat today that we're tapping into your knowledge and for general information. And if anyone out there listening has any specific concerns, we really recommend that you seek professional medical advice.
Yeah.
That's a good caveat.
Yeah. So you've worked with so many international teams and so many athletes over the years. You've probably seen and treated every issue and concern there is in the book now, I guess.
I've seen a lot of stuff across different sports. And I guess that's a cool thing about my profession, is that I work across sport, and each sport has its own unique raft of problems, right? Like I always talk about swimming as a really unusual sport. Like if aliens came down to Earth and looked at us pulling ourselves along in water with their arms, you'd be like, what are you doing?
Yeah.
You know, I guess it's the same for cycling. Like, what's this machine that you're riding along? And so with every sport, there are these unique injury and illness patterns that go with that. Of course, there's a load of commonalities across sport as well. So, I've been lucky to have worked in a few different sports so far.
So one of the crucial reasons we have you on the show, and, you know, just from our history on highlighting women in sports, a lot of what we are going to discuss today is around female athlete health. Things like hormones, what are the specific injuries that impact them. So with the work that you have done with all the international teams in swimming, rugby, and also the patients that you see at the moment, what are the common injuries and issues that women come up to you for?
Yeah. So I guess we as women, we're prone to different types of injuries as we go through our sporting lives. And in our early sporting lives, we tend to follow a much more similar injury pattern to men, I would say. Acknowledging that we are very different to men in lots of ways, but depending on the sport that you do, the injury pattern will be pretty similar. So, it really does depend on the sport, but, in swimmers, we see lots of shoulder problems. In runners, we see knee, ankle, hip problems. In rugby, we see lots of contact injuries, so trauma-related problems. And that's the same across women and men. And I worked in women and men's rugby, for example, and a lot of the injuries that we would see would be the same. There's some interesting differences, particularly in contact sports, like concussion is much more common in women than men, double the amount of concussions in women than men. No one really knows why that is, but we know that's the case. And so we think it's multifactorial, so there's things to do with hormones, to do with our menstrual cycle, to do with the elasticity of our tissues as we go through our menstrual cycle. There's a bit to do with strength, so particularly neck strength. Like there's some good evidence that concussion risk goes up if your neck strength is worse, and women's neck strength tends to be worse than men's. So work specifically on that can reduce that risk. There's other things, again, in contact sport, but also in gym goers, I guess. Things like ACL injuries, more common in females. That's hit the press really recently with loads of injuries in in women's football and rugby recently, high-profile ACL injuries. And again, multifactorial. We know that's to do with how women move. The Q angle, which is the angle between our hips and our knees, is different to men. So our pelvises are wider to have babies. Can't change that. And that angle means that we put a little bit more stress on landing through the ACL. We know that in general, our stability is maybe a little bit worse inherently, and that's trainable for sure. And then we also know that there's a factor, again, of menstrual cycles. So we know women are much more likely to rupture their ACLs around the middle of their cycle, around ovulation time. So we see differences there in the kind of early years. And then as women move through towards perimenopause, so into 40s and 50s, there becomes a really kind of obvious pattern that I see, and this is particularly in clinic, of tendon injuries in women, and specifically around our pelvis. So there's a really interesting bit of research that's just come out of Australia on glute-med tendinopathy. So your glute-med tendon is the tendon that connects your bum muscle to your hip bone, so your femur. And glute-med tendinopathy is almost exclusively seen in women over the age of 40, so 40s and 50s, which is really interesting. It is seen in men too, but almost exclusively. And it's so common. I probably see 3 a week in my clinic at the moment. I work 2 days in clinic, so that's quite a lot of people per week. And this research that was done in Australia showed that, for a long time, we've known that exercise is important for glute-med tendinopathy. We work on strengthening the tendon. We work on lumbopelvic stability, capacity. So you see it a lot in runners. We also see it in women who are walking. But this research looked at exercise. It also looked at HRT, so using hormone replacement therapy. Yeah. And what it found was, so they randomized the groups, they gave them different exercise programs and HRT or no HRT. And they found that the only thing that made a difference to outcome was whether the woman got HRT or not. Oh. So for me, that's been pretty practice changing, that piece of research. I always used to talk to women about hormones and are they on HRT, are they not? Because clinically, it's been apparent for a long time to me that influence of hormones on tendons, and we know that estrogen particularly is really beneficial for tendons, makes them stretchy. So as we enter that phase in our lives, our tendons become less stretchy, more stiff, and we're more prone to injury and tendinopathy. But around this glute-med tendon, because of how, again, our pelvises are made, it seems to be much, much more likely. So now, and the specific HRT was topical estrogen, so estrogen gel. So now that is an absolutely vital part of my practice for women with specifically glute-med tendinopathy. But I suspect that's something, as we learn more and more, will become a big part of our treatment for most tendon problems in women. So there's definitely a shift in what I see clinically as we go through our lives as females.
Hearing you speak, and I know Afshan's got a question about, menstrual cycles and periods and everything, but it was really fascinating. I used to play rugby in high school and a little beyond that for a club. And, I guess a couple of things is that it's fascinating that women are affected more by concussions. Now when I know more about brain health, I'm like, oh my goodness. Rugby is a great game, but you definitely are prone to, brain injury and concussions and things like that. But I guess one of the things is that down to a lack of research, like that we didn't know that before? Because it seems like, and I've read and heard in other places, there's a real deficit when it comes to women's sports, women's medical research in general. It's only become, in the medical profession, people are like, wow, women are, so physiologically different to men.
Yeah, I think traditionally, sports medicine research has been done on men, and the reason for that is, women have these menstrual cycles, so that changes everything, and so you can't rely on those results because it depends when you do it, which is correct. However, it's not a reason not to look, is it?
It's more of a reason to look.
Yeah, absolutely. And so that is definitely changing. Like the amount of research that's being done specifically on women and specifically on hormone effects in women now is massive. The concussion thing, for sure. Like I started working in rugby in 2009. And then the way that we managed concussion was, okay, well, someone's had a head knock. Let's just watch and see how they get on. We just didn't know as much. And the amount that we know about concussion specifically has just exponentially exploded over the past couple of decades. And so how we manage it now is totally different. And definitely then we had no idea that this increased incidence in women was a thing, and now we have so much more data on it. That's been a real progressive area of medical research, I would say, recently.
Yeah. Like Dawn mentioned, I mean, when I became an athlete, I think one of the only concern I had was, how do I train when I have my periods, or how that impacts my training? I mean, a lot of what you've spoken about, some of it I've heard of just through my journey as an athlete. But how common is this knowledge? I mean, research aside, which I'm pretty sure not, like, if you're not in the medical profession, you're not going to go through all the research that is out there. But just amongst coaches who train athletes, female athletes, what is the knowledge right now? What are the gaps, and what are the opportunities to actually educate them about this?
I think it depends on the coach massively. Some of the coaches I work with in the highest level of sport are absolutely on this, male and female coaches. Like we spend a lot of time at the highest level talking about how we can specifically benefit our female athletes, and we screen for female athlete problems. Like we proactively look for that and address that. And so I think at the highest level of sport, it's well known, and it's you talk about these kind of benefits and threats, and we can use it to our benefit for sure. The menstrual cycle particularly, like that's a really common thing that you just said about being worried about how do I exercise on my period. Well, actually, when you're on your period, you may perform best.
Actually, I do perform better.
I got a
100%.
PB in running.
And that's really common. Paula Radcliffe broke the world record for marathon. She was on her period. Do you know, like she complained of period cramps and broke the world record. So, it's a distraction, isn't it? Like,
actually, when I'm cycling and I have cramps, they kind of subside as I keep going.
And that's medical fact. Like it's a low hormone phase of your cycle. We know that people perform better, but the perception is I don't want to have my period. Now sometimes that is just logistics, isn't it? If you're a diver or a swimmer, you don't really want to have your period, and that's understandable, but we shouldn't be scared about that. We should be working with our hormones. I think at the lower level of sport, it's probably not that well known about, because it is still relatively recent information, and also we're not entirely clear still. Like we still don't know for sure what is best and how we can work with that best. There are lots of theories, but there's no there needs to be some more hard evidence before we can say, well, this, and I suppose it's a bit like everything in medicine. There's no one size fits all approach. Obviously it depends how your periods affect you. Like it's no good me saying, you'll run the best on your period if you're doubled over in bed. That's just not going to work. So definitely more research needed, but I think the awareness is growing for sure.
I did 3 out of my 4 ultra cycling races on my period, and I mean it's more logistical annoyance, right?
Totally.
But I really didn't, it wasn't a real physical difference for me, I felt. But it's interesting you say that. Like I remember, going to some coaches here, and one of the coaches is like, "What's wrong with you?" And I'm like, "I'm on my period," and he just turns beet red. But that is changing. Like my cycling coach is really, he fully knows all about a woman's cycle and implements it into his training and stuff. So hopefully that'll get better.
I think so. I don't know about you, but I remember when I was at school, people using their period as a reason to get off PE. That was like the classic excuse, wasn't it? And that response to I'm on my period, beet red, like run away. Like hopefully that's going to change. Lots more women are speaking out. Like I don't know if you saw in the press recently, but the England women's football team have changed the colour of their shorts. Like, it's these little things that just make it more normal, because it is normal, isn't it? Right? Like 50%. Like we should be able to speak about it and not be embarrassed,
100%.
I think.
Yeah. So one of the issues I think it is also very dear to me, because I have gone through eating disorders in the past. But something that has increasingly come up amongst female athletes is low energy availability. Also associated to REDs in sports. I'd really like for you to break that down for us and help us understand why it is important to understand this, especially as far as female athletes are concerned.
I think, so the first thing to say is that eating disorders in sport and in sports people are incredibly common. And again, we need to work harder at that for sure. But there's some horrendous statistic. I think like 45% of female athletes have some sort of disordered eating at some point in their career, which is awful, isn't it? And again, like we should be screening for that and proactively approaching that. In elite sport, it's harder, isn't it, when it's not elite sport, because you don't have a doctor phoning you once a year or even more than that, so it is really common. And it's more common in certain sports. So it's more common in sports where clearly you have to make weight. So things like boxing. It's more common in sports where power to weight ratio is important. So cycling and running.
So what is it exactly? Is it looking a certain way, or is it like, what is NEA?
Depends on the,
right.
Good question. I guess the answer is it's multifactorial, always, depends on the person. The theory is that I think it's a bit of both, actually. The theory is that in those kind of power to weight sports, it's more about performance. So if you're lighter, you might perceive that you may run faster and that, or cycle more effectively faster, which may be true to a degree, but not past a certain point. In aesthetic sports, so diving, gymnastics, the theory is that that's more to do with pressure on how those athletes look. But if you talk to athletes, it's always a bit of both, right? And an athlete with disordered eating often will talk about, well, I worry about how I look in because most sports you're wearing pretty minimal clothing, right? Tight clothing, small shorts, bras, swimming costumes. So there's this whole kind of cumulative effect. So I don't think we can blame it on one thing or the other. I think it depends on the person, it depends on the circumstance. But in terms of low energy availability like that, is really common. And low energy availability is not an eating disorder. Yeah. It's not being able to meet your energy requirements through what you're getting through your diet. And often that is not purposeful. People are not restricting their eating. They don't have a body image disorder. They don't have disordered eating. They are just maybe doing too much and eating too little. The problem with low energy availability is that, exactly as the name suggests, it's like driving a car without petrol in it. It is detrimental to performance. Right. And if that is allowed to continue, then consequences come from that in terms of the physical effects of low energy availability. Relative energy deficiency in sport, so RED-S, is the kind of medical terminology that describes those physical consequences of low energy availability. And the question that I'm always asked is like, is this RED-S or is it low energy availability? And the answer is it's grey in between those. There's no like one cutoff that says that somebody is now in RED-S, whereas previously they were.
But the factors that bring it together are almost identical or the same.
Yeah,
right?
And there's a traffic light system. The International Olympic Committee did a load of research into this and published this kind of best practice paper. And there's a traffic light system that you can use to decide whether somebody is like reaching a diagnosis of RED-S. And so that's things like having no periods, so periods having stopped. So that happens, it's called functional hypothalamic amenorrhea, and it happens because your body decides you're not in a state to have babies. Like if we take it back to evolution, that's what happens. So, when we were cavemen, and there's no food and the dinosaurs are chasing us all the time, we don't want to get pregnant, right? So the body switches it off. And that's exactly what happens when we're over-exercising and under-fueling. So the body switches off that reproductive system. So that's a kind of flag for RED-S. Bone health then suffers. So with low hormones, you see increased incidence of bone stress and bone thinning. So osteopenia, which is milder thing of the bones, and osteoporosis, which is that kind of clinical diagnosis of thinning makes it sound like they get smaller. They don't. They just get less dense, like low bone density. It can be associated with disordered eating and eating disorders, but not always. It can be because there's a fine line, right, in sport, and body mass is a performance metric. We have to acknowledge that. But that fine line, like anything in sport, can sometimes be pushed a little bit too far.
I mean, for me, I probably, coming up like in university, I was in university in the early 2000s and stuff. And, I think there was a whole resurgence recently of like thin is in, which is worrying. And definitely when I was, at that age, really impressionable and stuff, I would say I didn't have an eating disorder, but definitely disordered eating, on occasion. And sport for me actually, made me look at food in a whole new light. Food is fuel, to me now. And I'm less concerned about the aesthetics and more concerned about how I'm feeling on a bike. And definitely with ultra cycling, like food is key.
You have to
when
eat
you're
too,
burning,
right?
thousands and thousands and thousands of calories in a day's cycling, like you have to eat. There's no two ways about it. But one of the things I think, my coach even said this as well, some of, his colleagues who are cycling coaches, when they have a lot of women, they're all concerned with weight loss. And then I hear particularly, I've got a different relationship with food due to ultra cycling. I always eat before I train now. Maybe I didn't before, but I have to, or else I'm just not going to have a good ride. But you hear these conversations in the cycling community too, oh, you should ride fasted. What would you say? Like, is that advisable to do that or...
Not if you want to perform. I think if we're looking at the bare bones of what we're trying to achieve from training, obviously everyone has different requirements from their training, right? Maybe not everybody wants to improve, but if you are looking to make physical gains from your training, then you have to give your body the building blocks to do that.
Yeah.
And so personally, I don't think that, especially for something like ultra cycling, like, why it's going back to that car analogy, like why would you drive your car with no petrol? You can't, right?
Yeah.
So you can try and get through, and your body has some cool and clever ways of pulling energy from other sources. But what I see in clinic a lot from people who train fasted and then sometimes, we all have busy lives. You can finish your cycle and before you know it, it's 3 hours and you've not eaten, or, you go take the kids to school or go to work. And the problem with that is you're not giving your body the building blocks to recover at the time that it needs it. And so it starts to pull from elsewhere because, like I said, it's clever and it will do that. But that's when I see things like bone stress injuries. So there's some good evidence that fueling within the first 20 minutes post-activity can reduce that. Like you give yourself the building blocks for recovery, and that bone turnover is a normal part of exercise. Like you have bone stress related to activity that turns over all the time. And those bone stress injuries only happen when your body can't keep up. And if you exercise fasted and don't fuel afterwards, even if you get the right amount of calories in the day in total, if you're not putting them at that period of time, your risk of bone stress goes up. So for me, I think it's all about eating the right stuff around when you want to be exercising. So some protein, some carbs before and after in that little golden window of opportunity is so important.
You mentioned some of the, like, the short term or, symptoms of LEA, not having your period or loss of bone density. What are some of the long-term repercussions?
Yeah. I mean, there's loads. It affects every body system, right? So, and there's some pretty scary stuff, like if you really drill down. So if you think you're putting yourself into like a premature menopause, essentially that's what you're doing. You're switching off your hypothalamic axis. Low bone density is a part of that. Low mood comes with that. There's cardiovascular effects. So we know that with low estrogen, women are more likely to get atherosclerosis. So that's furring of the arteries, which is something that should happen when we're much older, The effects on metabolism, like your metabolism drops because you go into this starvation mode. Your body's trying to protect yourself. There's no system that it doesn't affect.
Right.
That's probably the short-term answer. And for that long-term health, it's not a good place to be. And so what we should be doing is trying to pick that up early, trying to pick it up at the low energy availability stage before we get to those consequences. Because actually the body can put up with a lot before it starts to switch off your menstrual cycle,
I started training when I was at the peak of my eating disorder. So you can say that I got LEA because of my eating disorders. I think one kind of fed into the other. I lost my period, like you mentioned. That's a very common risk factor, and it happens. However, I didn't have all this information back then when I was starting off, and I didn't kind of associate the two. And I was like, okay, I've lost my period because I did lose a lot of weight at the same time. They'll come back. I didn't have a coach that at that point to tell me that, oh, you need to go and kind of see a doctor because this is not right, or you're under eating and overperforming. Can coaches identify this, and what are like the risk factors that they should be looking out for, or, the red flags that they should be looking out for when they're coaching female athletes?
Yeah, it's a good question. I think if you are committed to being a coach, that's part of it, isn't it? It's the health of your athletes is partly your responsibility if you're programming for somebody. And so, I think as a coach, watching for someone who's maybe actively not fueling around training, going for breakfast, people not eating or skipping that breakfast, people losing significant amounts of weight, having those conversations, and I suppose normalizing those conversations around food. And this shouldn't be taboo, just like periods, there is still a taboo around disordered eating for sure. But I don't think there should be. I think we should be able to have conversations around weight that don't feel threatening, that are professional and not banter. Like that's important, I think if we can get to that stage, then there's a much more open dialogue around that. So there are a few more like tools that are formal, like for assessment tools. There's a RED-S clinical assessment tool, but that's clinical. I guess from a coach's perspective, they'd want to be having a good relationship with a doctor that they could refer to for further assessment. Some sports use that don't have a doctor, so like kind of sub-elite level, use the BETA-Q as a assessment for eating disorder. So that's like a self-assessment tool, BETA-Q, that you can just fill out. That is something that a coach could use and use it as a flag and send those people on if they were concerned, or maybe use that as a framework to talk through with their athlete if they were worried. I think having a bit of a framework around a discussion, if it's something they didn't feel comfortable with, would be a good start, and the BETA-Q is a good way to do that, but the start of that is having a good relationship with the athlete and an open dialogue, isn't it? Otherwise those conversations can't be had.
Do you think, there's been a reckoning really, particularly in North America, when it comes to gymnastics and, from across many different issues within that sport, but obviously diet, and pushing these athletes to the extreme is one element of that. Do you still think that's prevalent in sport?
I think it's less prevalent now than it was, particularly in those aesthetic sports. I think at the top level, loads of work has been done. And so I would hope that across most countries in the world now at the top level of those athletic sports, everyone is singing from the same hymn sheet, and that there's a professional, structured, performance-based conversation. But I don't think that happens at all levels of sport, because I think, and unfortunately, I think that probably is coach-led at grassroots, in that it tends to be in those sports, right, that people are coaching who are athletes, and this is how I was spoken to as an athlete about my body, so this is how I'm going to speak to my athletes about their bodies. And so that just takes a little bit of training, doesn't it, to change that attitude. I think, and hopefully this will be like a top-down trickle, right, that the way that we approach it changes at the top level of sport, and then everyone else sees that and changes their approach too. I hope.
This may be a little controversial because sports is about performance, especially if you're an elite sport. But do you think we should be kind of looking at sport more than performance and like actually focusing on the long-term benefits on the athlete, not just the short-term performance that they can like bring home a medal or bring home a trophy?
Yeah, of course. Definitely. Particularly from a medical perspective, like as a sports doctor, you have your foot in two camps. There's the performance side and there's the health side. And I believe as a doctor, you have to have a foot in both camps. That's super important. You can't be all in the performance side, but equally you have to acknowledge the difference in elite athletes to people who you might see in clinic who like to go for a run at the weekend. Like, that is different, but you have to think about the long-term health of the athlete as a doctor. Now, some of those conversations, like, they will be different, and I have these conversations in clinic every day. You know, I see someone like the commonest thing that I talk about this with is people with pelvic pain. So there's a type of injury you can get where you get pain in your pelvis. It's really painful and it takes ages to rehab from. Now, if that were an elite athlete, it's really common in football, change of direction sports. If you have the World Cup final in 3 weeks' time, we would talk about doing a steroid injection to mask the pain and allow you to play, because that's the goal.
Yeah.
And then you deal with the consequences of rehab. But if that would happen to you, I would be saying to you, we don't have a World Cup final in 2 weeks' time. Maybe we do, but you know, what we're trying to do is get you better long term, get your health good long term. And so there is subtle differences in how we would approach it, but the overall focus as a doctor should be on that long term health, definitely.
Because I train with a lot of triathletes at the moment. I myself am not a triathlete, but the ones that have these big goals, right? Like, you know, they're maybe doing an Ironman, for example. They change their diet drastically because they want to be a certain weight to run, or because if you're lighter, you run faster. You're faster on the bike. You're probably faster on the swim as well. So it's just like sometimes I question that, because of course I have a background of eating disorders. So every time someone tells me that they're on a diet, I kind of like just completely like, you know, close up, and I'm just, you know, I'm probably even questioning every decision they make. So to me, it's just that, should they be prioritizing performance over like their health at this point? Yeah.
And I guess that goes back to that low energy availability, doesn't it? Like, you know, if you're 130 kilos and you want to get down to a normal BMI, then that's positive for your health. But if you start off at 50 kilos and you want to get to 45, then that's not going to be beneficial. I guess the other thing I would say, particularly about endurance sport and weight loss, is that exercising for that level of endurance sport in a calorie deficit, which is what you would have to be in to lose weight, is tricky. And that's when we see those bone stress injuries. That's when we see tendon issues, because you're asking a huge volume from your body, particularly if, because most of these people, right, they're not just doing triathlon and then going home and sleeping, right? They're not, they have families and jobs and, you know, you have a bucket and it's a certain size, and everything you put into that bucket counts. Training is part of that, but everything else in your life is a part of that. And there's only so much capacity that bucket has. And if you overdo that from any part, you know, that red S risk factor is stress and cortisol response that comes with that. And so people that do that volume of stuff and diet at the same time, I worry about. Because I see injuries for sure.
I mean, I'm quite fortunate, touch wood. I've had no injuries related to sport. It's mainly just me being clumsy in my life. But it's, you know, it's really interesting to hear you say that, because like my first ultra, I was definitely like, I didn't understand fueling. It wasn't like I was trying, but I just didn't simply eat enough because I just didn't know, you know? And I came back from that race and I got so thin. Like I lost probably like 4 or 5 kilos after the race. Like in addition to what I lost on the race. But I'm just so thankful, like nothing, you know, my body wasn't, I was probably really prone to injuries at that time. And I'm just really thankful that, I didn't get any after
got away with it.
Yeah, to be honest, I mean, when I started in endurance sports, you know, working with my coach, and I have a fantastic coach who actually understands this. I think we had a lot of discussions about how I feared increasing my calorie intake or my carbohydrate intake while I was riding or while I was running. I would eat well outside of the training, but like during the training, I'm like, oh, I've eaten everything the night before. The the moments before the run or the ride, why do I need to eat during? And I think it was like a relearning and a rewiring process for me. And it's still a process for me because it's just something that I manage on a day-to-day basis. So it's just every time I sit down with him and we have a conversation, it's very productive because it has shown me that I have become a better performer only because I'm eating well, right? Like it's not like the more I restrict, the worse it becomes. And the worse I feel after it as well. So,
We're going to change course in a minute. But before we do, I wanted to ask if there's any last words related to, food, performance, LEA.
And some of the current work that you may be doing in that area as well.
Yeah. I guess for me, it's just the importance is just awareness, I would say. And I think you hit the nail on the head there, just saying like you just weren't aware of how you should be fueling. And I think that is really common. And I see a lot of people in my clinic setting who are tired. They come feeling tired and they don't understand why. And when you, or they've maybe had, one thing I haven't touched on is the immune suppression that happens with low energy availability. And they just don't understand why. And actually, when you pick it apart, like, it's not surprising that that person is tired. They're pushing their body on not enough fuel. And so I think it's easy to look for other solutions, isn't it? And hope that everything else is okay. But actually, I think if we are really critical of what we're asking and what we're putting into our bodies, then we can usually make sense of that kind of thing. And the early identification and adjustment is key. We're not asking people to eat huge amounts that make them feel uncomfortable. It's not about that. It's about eating enough so that you're not in that deficit. So awareness would be my take-home message.
This is the Mettleset.